So here we're going to continue our discussion of the newborn neurological disorders. So in part one, I talked about hypoxic ischemic encephalopathy, neonatal seizures, and how we manage those, and congenital hypotonia. Here we're going to talk about the very important neural tube defects. The USMLE loves to test neural tube defects. And these are something that are encountered often in pediatrics. Actually, about 10% of the population has neural tube defects, whether they know it or not. And it's important to know the manifestations of these, the prognosis, and the management of these five. Now, there are other neural tube defects, but we're not going to talk about some of those rarer ones. We're also going to talk about two malformations, the Arnold-Chiari Malformation, which is important in and of itself, but it's also important because it's associated with some of these neural tube defects. And then we'll also talk about the Dandy-Walker Malformation, which is pretty rare, but the thing that's important about it is that the USMLE loves to test it. And so we're concerned about points here, too, in addition to clinical performance, because you're probably reviewing because you're going to be taking this test soon. So the neural tube defects include really two classes that we're going to talk about. Spina bifida, which affects the spine. It means bifurcated spine. It's just Latin. And this has two different classes. Spina bifida occulta, which is a disease process in and of itself, and then spina bifida cystica, which is visible to the naked eye, and that includes meningocele, meningomyelocele, and myeloschisis. And those all have different prognoses, different. We're going to treat those differently. We're also going to talk about anencephaly, and this is a problem of the head rather than a problem of the spine. Now, these other ones we're not going to talk about because they're rare and I've never ever seen them tested on the USMLE. Are Myeloschisis, which is basically a spina bifida that includes the entire spine rather than just one smaller area. Encephaloceles, which is sort of like a spina bifida that happens in the head, but it's not anencephaly. And then Anencephaly, which is sort of an encephalocele that happens at the back of the head, at the occipital prominence. And that part of the head is technically called the inion. And so that's where it gets its name from. So we're not going to talk about those. We're going to talk about these five because these are the ones that come up on the test most often. This process is called neurulation, and this is where the process goes wrong when it occurs in the first month of embryonic development. And this is where the process goes wrong in babies who have neural tube defects. So you have this layer that covers the notochord, and it consists of ectoderm and a neural plate, and then this neural plate border, which separates the neural plate from the ectoderm. And what's going to happen is this tissue is going to invaginate, so the neural plate's invaginating down into this like U shape, and it's going to draw the neural crest cells together. And ultimately, the neural crest cells will come together and form its own layer. So here they're separate. They come together, and the neural crest is going to join from both sides and form its own layer. Likewise, the ectoderm is going to join and form its own layer. So now you have, rather than this one layer, it's now formed three layers. See, so we got the ectoderm comes together, the neural plate border comes together, forms the neural crest cells, and then the neural plate forms this neural tube from invaginating and making a tube shape. These neural crest cells here are going to form the peripheral nervous system, and these are very important because these neural crest cells, if they don't migrate properly or they don't act appropriately, they cause a lot of different diseases, and it depends on the genetics behind it, but these are behind things like pheochromocytoma, Hirschsprung's disease, DeGeorge syndrome, multiple endocrine neoplasia, Van Recklinghausen disease, Waardenburg syndrome. So there's lots of different things that these neural crest cells are important for a lot of different parts of the body, not just the spine. So typically it's some point between 2 and 3 where you have a problem and you don't have a complete closure, and that's what's going to lead to a neural tube defect. So here's another view of how neurulation looks like. So here's where you have that invagination here, and ultimately it's supposed to close. Here's another view here. So I also wanted to bring up a couple things too. So the neural crest secretes a specific protein called bone morphogenic protein 4. I believe I was actually going off memory when I typed this, so I'm going to have to check afterwards. Hopefully that's right. But it is bone morphogenic protein. I believe it's type 4. And that protein is specific. It's specifically secreted by the neural crest, and that's going to help the dorsal part of the neural crest develop sensory neurons. And so that's why we have sensory neurons on the posterior part of the spinal cord. Likewise, this notochord down here, which is red, that secretes a protein called Sonic Hedgehog protein. It actually got its name from the character Sonic the Hedgehog, which is a really fun Sega video game when I was little. But that is going to help the neural crest develop motor neurons. And so that's why our motor neurons are anteriorly located. And so this is why we get this axial difference in the spinal cord. So here's where the problems come if you have an unfused vertebral arch. If you don't have a problem where you have any kind of herniation, that's going to be your Spina Bifida Occulta. So notice that there is really nothing wrong with the spinal cord or with the dura mater. You don't have herniation whatsoever. You just have an unfused vertebral arch. So looking from the outside, there's nothing wrong. Now you can get a tuft of hair, you can get a birthmark, you can get a dimple, but you might not have that, or it might not be noticed. So this is why it's called Spina Bifida Occulta, which means spina bifida that's hidden. Occulta means hidden. So this is Spina Bifida Occulta. This is a meningocele. So a meningocele is where you have a herniation, but it only includes the dura mater and the area containing cerebral spinal fluid, the subarachnoid space. But the spinal cord is exactly where it's supposed to be. Now here you will have a herniation, you will have something that's grossly visible on both on when you do sonography, prenatal sonography, and when the baby's delivered. Ultimately, babies who have anything that's visible should be delivered via cesarean section. That's a OB note that you should be aware of. Now this here is a Myelomeningocele. So in this case, you have herniation of both the subarachnoid space, but also of the spinal cord. And it's not necessarily the entire spinal cord that's herniated. It might just be in one spot. But in this case, that membranous sac includes nervous tissue. So this is the Myelomeningocele. And then this is Myeloschisis. So in this case, you have an open spinal cord that is that's directly exposed to the outside, consistent with the skin. So we're going to talk about all four of these. So this is another view here. You have your normal spine, Spina Bifida Occulta, meningocele, and Myelomeningocele. So neural tube defects are congenital deformities. This applies to all of them. Congenital deformities of varying severity that involves the covering of the CNS. And the long-term effects are going to depend on the severity of the lesion, and really which lesion it is, because those are the severity of the lesion. Spina Bifida Occulta is much less severe than Myeloschisis. Neural tube defects in general have a female preponderance by about 2/3, so about 60 to 70% of neural tube defects occur in little girls as opposed to little boys. It can be acquired via genetic mutation, or it can be congenital factors. And the big one that we think about is maternal folate deficiency. So that's why we want to make sure that all women of childbearing age are getting their supplemental folate. And that's important because it's not just the folate that you're taking during the first month of pregnancy, but also the folate that you've been taking before that. Now, it's also important too because that women of childbearing age are taking supplemental folate, because a lot of women don't know they're pregnant until about 1 or 2 months of gestation, and by then you've already had neurulation, and if the baby's going to have a neural tube defect, you really can't go back from there. So that's another reason why it's important that women of childbearing age in general are getting sufficient folate. So 17 to, okay, sorry, that should say 17 to 30 days of gestation. Sorry about that. So days of gestation, 17 to 30 days of gestation. That's when the neural tube defect occurs. All women who are pregnant are going to be screened at the second trimester prenatal visit. It can really be any time within like 14 weeks and beyond, but typically it's done at the second visit, which is about 16 weeks of gestation, and that can be done with a triple screen or a quadruple screen. Where I work, it's done via triple screen, but quadruple screen can be done as well. So this tests maternal serum levels of alpha-fetoprotein, estriol, and HCG. And then it also tests inhibin in the quadruple screen. So, wow, this is problematic. So my autocorrect decided to turn this into inhibit, but it is inhibin with an N. And so that's part of the quadruple screen, but you're always getting an alpha-fetoprotein, estriol, and human chorionic gonadotropin levels. Now, with neural tube defects, these are associated with alpha-fetoprotein elevation, but the most common cause of alpha-fetoprotein elevation is inaccurate gestational dating. So the older the baby is, the more alpha-fetoprotein is going to be in the maternal serum. So if you think the baby is only, if you think the baby's 20 weeks of gestation, but the baby's really 26 weeks of gestation, then you're going to say that the baby has an elevated alpha-fetoprotein, when in fact it's actually normal. So you want to make sure you have an accurate gestational date. So if the baby or if the mother comes back with an elevated alpha-fetoprotein, yes, we are concerned about neural tube defects, but what we want to do is make sure we have an accurate gestational date before we do any more invasive studies. Risk factors for neural tube defects, as mentioned, include folate deficiency. Another big one is anti-epileptic drugs, because those can interfere with folate metabolism. And that includes drugs like carbamazepine and valproate. Now, important to know, again, this is an OB note, but I may as well bring it up now, that it's important for the woman to be on anti-epileptic drugs if we're concerned that taking her off of it can cause seizures, because a woman having a seizure is much more harmful to the baby than her taking anti-epileptic drugs. Even women who take anti-epileptic drugs, only 1% to 2% of their babies are going to have neural tube defects. So it's important for women to be on anti-epileptic drugs. We don't want to just haphazardly take them off of them just because they're pregnant. Other things include low socioeconomic status, usage of antihistamines and sulfonamides. Also, women of Hispanic descent are also at increased risk, probably due to genetic reasons. So this is a quad screen here. I just want to include the inhibin. Here it is appropriately spelled. So with neural tube defects, you will have an alpha-fetoprotein level that's high. The rest of them, though, are going to be normal. And so alpha-fetoprotein can be due to inaccurate dating. That's the first thing we think about. But once you've confirmed that the gestational dating is appropriate, then you look to things such as multiple gestation. If you have twins, then you're going to have a higher level of alpha-fetoprotein because they're both making alpha-fetoprotein. And then other things that it can be, in addition to the neural tube defects, include gastroschisis and omphalocele. Basically, the way to think about this is if any part of the body is exposed, any part of the fetal body is exposed to amniotic fluid that shouldn't be exposed, so if you have a gastroschisis or an omphalocele or a neural tube defect, then that's going to cause an increased secretion of alpha-fetoprotein. But by far, neural tube defects are going to be the thing to think about when you have elevated alpha-fetoprotein. But if you do get a neural tube defect, or a high alpha fetoprotein, you can do an ultrasonography and look for it. And usually with gastroschisis and omphalocele, you'll be able to see that as well with your sonography. Now the trisomy 21, 18, and 13, they have their own quad screen levels, but we're not going to talk about that here. Spina Bifida Occulta is a mild to subclinical defect in which the meninges do not herniate through a bony defect, but the bony defect is still there. This is going to be covered with skin. You're not going to see anything abnormal, but sometimes you can get a little dimple, or you can get a little hairy patch, or a birthmark. That's going to be it. The symptoms are going to be limited to cutaneous stigma. You can diagnose this with vertebral x-ray and MRI if you see any of these cutaneous stigma, but in a lot of babies, they're not going to have those. And so, as a matter of fact, 5 to 10% of the entire population has spina bifida occulta, and I would guess that a majority of those people don't even know it. So this is very common. The treatment, really none is necessary unless there's associated anomalies. The big one that we are concerned of is tethered cord syndrome, but it's really a minority, vast minority, small minority of SBO patients that will wind up having tethered cord syndrome. But the symptoms of this will include leg weakness, foot anomalies, low back pain, gait abnormalities, and occasionally bladder continence issues. And these will present during childhood, not during neonatal period so much, because the baby's not walking around yet. So that is an associated anomaly, but typically SBO is subclinical unless there's those stigmata. So here's an example. You have a hairy patch. You also have a nevus flammeus birthmark here. There's another nevus flammeus. They tend to occur right above the anal crease, or luteal crease. And then here's a dimple. So you can see that, like a little puckering of the skin, and then a little bit excess hair. Although this person is kind of hairy, but a little extra hair there. A meningocele is a herniation of the meninges through the bony defect, and it's covered with skin or a membrane. Now, it's not always covered with skin. It might just be a membrane, and that's going to affect how we manage the baby. But there is no involvement of the spinal cord, so typically these babies are not going to have long-term sequelae. The symptoms are usually none, unless since the spinal cord is not affected. But it can be associated with syringomyelia, tethered cord syndrome, or hydrocephalus. If there is associated syringomyelia, hydrocephalus, we'll probably note that in babies, but tethered cord syndrome usually doesn't present until later. For diagnosis, you get a vertebral x-ray, MRI. This is going to be treated with surgical correction. Now, particularly we're thinking surgical correction early on with babies who don't have skin that's covering the meningocele. If it's just a membrane. We're going to need to do surgical correction pretty quickly on these babies because they have an exposed surface that can get infected. So there's two reasons why we would do surgical correction right away for these babies. And that is if the membrane is exposed, you don't have any skin covering it, or if maybe you do have skin covering it, but it's leaking cerebral spinal fluid. In this case, we are going to cover the meningocele with a moistened sterile sponge. We don't want to use gauze because gauze can stick to that membrane. And then you're going to be sending these babies in for surgical correction. You also want to make sure that these babies who have an exposed membrane, you give them broad spectrum IV antibiotics because they're at risk of meningitis. The supportive management is going to be used for bowel or bladder problems, but it's a little less common in meningocele than in myelomeningocele. And then if there's any limb weakness, you can send these children off for occupational therapy. So here's an example of a skin-covered meningocele, and usually these are skin-covered. And here's another one. So you can see it's just like a little bump. Really nothing else to it. And if it's skin-covered, it's a meningocele. You can bet your money on it. A myelomeningocele is a herniation of the meninges and the spinal cord. So there's spinal cord in that herniation as well, and this makes it a little more tenuous. And typically the lesion is going to be raw and exposed, and so that makes it more problematic because you have a risk of meningitis. The symptoms are invariably flaccid paralysis of the lower extremities, absent DTRs, and anesthesia in the lower extremities, because usually here, because you have exposed tissue, you're going to have an effect on the nerves. And also because of that, the foot is not going to be developed appropriately, so you can a lot of times see club foot in these babies. Another thing you can see is hydrocephalus. We'll come back to that. For diagnosis, it's the same pretty much as before. You're getting vertebral X-ray and MRI, but in this case, you should, when it's a myelomeningocele or you suspect myelomeningocele, you should get an MRI that also includes the cranium and the neck. And that's because there is a high coincidence of Chiari-2 malformation, which is that Arnold-Chiari malformation, in about 75% of cases, so the majority. And if you have a baby with Chiari-2 malformation, they are at risk for hydrocephalus. Now for treatment, it's going to be surgical correction, as usual. You're pretty much treating this the same way as the myelocele, the meningocele, as far as we are concerned on non-surgical end. So you'll cover this with sterile moistened sponge, give them broad-spectrum antibiotics, and send them over for urgent correction. And then the Chiari-2 malformation will also typically require surgical management as well, because these babies will ultimately develop hydrocephalus, so they'll usually need a shunt. So here's a myelomeningocele. This needs to be covered ASAP. I think they're only uncovering it so they can give you that nice picture. Here's another one here. So you can see it's sort of just a membrane, and then this here you have that exposed tissue. Myeloschisis is the most severe form of spina bifida, and it's due to failure of the neural folds to close. And so in this case, because the neural folds don't close, the spinal cord is directly exposed, and all you pretty much have covering the spinal cord is this really, really delicate semi-transparent membrane. Symptom-wise, it's similar to myelomeningocele. For diagnosis, you're going to be doing the same thing, getting a vertebral X-ray and MRI, also including the cranium and neck, because you have an association with Chiari-2, and that's going to be associated in a large number of cases. These babies need to be treated ASAP. They'll get surgical correction. They need IV antibiotics. You want to cover that exposed tissue. But these babies just have a somewhat worse prognosis long-term than myelomeningocele. And then, of course, we need to also treat the Chiari-2 malformation. So here's myeloschisis. So here you see exposed spinal cord. Anencephaly, there's not really much to know about this because this is incompatible with life, so there's not much to do as far as treatment. But this is a failure to close of the anterior neuropore, so the very anterior part of that neural canal. If that doesn't close, then you're going to have exposure of the brain tissue, the very, very top end, the cranial end of your central nervous system. And that exposed brain tissue degenerates, you don't really get development of the skull, and so you basically have a flat head. And so because of that, it is incompatible with life. Now, it's generally only the cortex that is degenerated. The brainstem is usually intact. And so the baby may be viable at delivery, but these babies will ultimately die. The brainstem is usually, a lot of times, okay. And so if the brainstem is okay, they'll be able to breathe on their own, but ultimately there's going to be infection, and they'll die from that. So here's an example of anencephaly. It's pretty easy to tell these. A lot of times, I don't think you're going to need imaging for these. And they can be diagnosed prenatally as well. So here is an ultrasound. You see the flat head here. Okay, Arnold-Chiari malformation, or a lot of times just called the Chiari malformation, is a protrusion of the cerebellar tonsils through the foramen magnum, which is that big hole at the bottom of your skull. And this causes a displacement of the caudal brainstem, which leads to a lot of symptoms. As far as classification, this can present during adulthood or it can present during infancy. The Chiari-1 malformation, this is really much more complex than I'm making it look here, but as far as the test is concerned, and I mean, essentially, this is the way it's classified. So Chiari-1 malformation is pretty much just the Chiari malformation all by itself. Chiari-2 malformation is essentially the Chiari-1 malformation plus a meningomyelocele, or a meningocele. So as far as we're concerned with neonates, we're concerned about the Chiari-2 malformation. If you're talking about adult medicine, the Chiari-1 malformation is what you're concerned about, because this Chiari-1 malformation tends to present in adults in their 30s who have hitherto been asymptomatic, and now they're coming in with progressive stumbling and vertigo and difficulty swallowing, lower cranial nerve paralysis, and so forth. This is rarely diagnosed in infants. Chiari-2 malformation, that's that Chiari malformation that occurs in association with meningocele or meningomyelocele. This can lead to hydrocephalus because it can block off the fourth ventricle, and there's an increased risk of syringomyelia, epilepsy, cortical dysplasia, and then the most feared complication is apnea and paralysis because this is pressing up against the brainstem. As far as diagnosis, is cranial MRI. That's why we were getting the cranial part of the MRI when we were working the baby up for meningocele or meningomyelocele. And what you're going to notice is cerebellar tonsillar protrusion through the foramen magnum, which will obliterate the cisterna magna. The cisterna magna is a collection, little duct of collection, a little corner where cerebral spinal fluid collects right underneath the cerebellum. It's just Latin for big cistern. And this can be diagnosed via sonography prenatally, but I'm not sure if you'll get a picture of that or not on the test. For treatment in infants, you'll get a ventricular peritoneal shunt, and that will correct the hydrocephalus as well as the displacement and restore intracranial pressure. Let's look at some pictures of this. So if you get a picture on the USMLE of Chiari malformation, it will probably be an MRI. So if you look at this, you notice that there's really nothing wrong with the cerebrum, nothing wrong with the hypothalamus, the pons is fine, cerebellum looks fine, but the problem here comes with the cerebellar tonsils. These shouldn't be this far down, and they're also impinging on the brainstem. So the way that you can diagnose Chiari malformation, and typically the standard is that if the cerebellar tonsil protrudes more than 5 millimeters past the foramen magnum, it's considered a legit Chiari malformation. Now, there are a lot of technicalities in that, and a neurosurgeon or a neurologist would probably take issue to that, but that's the very basic definition. So where's the foramen magnum? Notice that you have this little triangular bone here and this little triangular bone here. The foramen magnum is the space in between that. So if you draw a line, so here's your triangular bone here, triangular bone here. I don't know if it looks triangular grossly, but if you right down the middle view here, you'll have a triangular bone here and a triangular bone here. When you draw a line, you will note that there is definitely more than 5 millimeters of protrusion. There shouldn't be any protrusion, but if there is, you're thinking Chiari malformation, especially in the context of symptoms. Okay, so here's another one. So here's triangular bone here. That's not what it's called. I'm just calling it triangular bone. Triangular bone here. So the foramen magnum is right here. You draw your line, and yes, there is cerebellar tonsil protrusion. And it is also impinging on the brainstem here. Okay, this one's a little less pronounced, but it is still there. All right, the Dandy-Walker malformation is very rare, but it's not very rarely tested on the USMLE. They like to test this one. And it is a congenital malformation involving the cerebellum and the fourth ventricle. And the primary cause of this is agenesis or hypoplasia of the cerebellar vermis. So it's just the middle part of the cerebellum. And because you have agenesis and or hypoplasia of the cerebellum, you're going to have a small cerebellum. The result of that is that you're going to have an enlarged posterior fossa. And it's just enlarged because you have more room there. There's less cerebellum, so there's more room for the fossa. And this Dandy-Walker malformation can also be associated with atresia of the foramen of Magendie, and that results in hydrocephalus. The symptoms present early on in infancy. You can have occipital bulging right in the back, and that's going to make sense when you see pictures of these. Hydrocephalus because of the Magendie atresia, irritability, vomiting, lack of muscle coordination, cranial nerve paresis. So you got the irritability and vomiting probably because of the increased intracranial pressure, lack of muscle coordination probably because of issues with the cerebellum. There can also be associated malformations of the heart and the limbs, so you'll want to do an echocardiogram. Limbs you should be able to notice grossly, and then also the vertebrae, and what we're looking at is for fusion of the vertebrae, so you're going to want to get, it's not the diagnostic test, but you're going to want to get a vertebral x-ray. A lot of these babies that have this will have multiple fusions of the vertebrae. That's called Klippel-Feil syndrome. And you'll also, a lot of cases, be able to notice this grossly because these babies will have shortened necks or they won't have the same range of motion as a normal baby. To diagnose Dandy-Walker malformation, you just get a cranial MRI that's going to demonstrate your enlarged posterior fossa and the hypoplastic cerebellum. This can also be pretty easily diagnosed prenatally via sonography. For treatment, you're just going to shunt to relieve the hydrocephalus, so you just refer these babies over to neurosurgery. So here's a normal brain right here, and here is a Dandy-Walker malformation. So this is quite obvious. So because you have a hypoplastic cerebellum, you've got all this space here. And it looks like there's elevated ICP here, hydrocephalus, because you've got some fluid pushing up on the occipital lobe. And you also have, looks like, some fluid up here too. So here's another one. Here's your hypoplastic cerebellum. Notice, here's your tonsils, definitely not protruding. So it's really kind of the opposite, in some ways, of Chiari malformation. Here's another one. Here's your triangular bones here that we were looking at in Chiari malformation. Okay, so here's a prenatal sonography, and you're just looking at the occiput, and here's this big space here, this hypoechoic space, and that is that large posterior fossa. And that's typical with the Dandy-Walker malformation. All right, I believe that's all I've got for you.